Imagine a futuristic, cutting-edge anti-aging clinic.
Oh, sure.
Right. Like you might picture these pristine, highly sterile labs, maybe some glowing lasers and, complex genetic therapies.
Yeah, very sci-fi.
Exactly. But what if I told you that one of the most advanced frontiers in human healing actually relies on combining those high-tech lasers with, well, the DNA of a salmon?
It sounds completely like the plot of a comic book origin story, honestly.
It really does. But today we are looking at a highly specific, just incredibly fascinating question for you. Can intimate polynucleotides be safely and effectively combined with energy-based devices? So things like radio frequency and fractional lasers.
Right. And it is a very real, rapidly evolving frontier in urogynecology and in regenerative medicine as a whole.
So our mission for this deep dive is to figure out if these two, radically different approaches, high-energy machines and marine-derived DNA, can actually work together to heal the human body.
And we have a pretty massive stack of sources to pull from today to figure that out.
Oh, yeah. We are looking at official medical guidelines from the UK's National Institute for Health and Care Excellence, or NICE, alongside protocols from the American Urogynecologic Society, which is AUGS.
Plus, FDA safety communications and a lot of peer-reviewed clinical studies from journals like MDPI.
It's a dense stack of medical literature.
It is, yeah. But the underlying biological mechanisms at play here are genuinely remarkable once you break them down.
Okay, let's unpack this, because before we can understand why on Earth a doctor would combine laser beams and fish DNA,
Which is a wild concept.
truly wild, we have to understand how these tools work individually first. And honestly, we have to address the massive controversy surrounding them too.
Definitely.
I want to start with the heavy machinery, basically. Energy-based devices, or EBDs.
Right. So in the context of intimate health, clinics generally rely on two main categories of EBDs. First, you have lasers, specifically fractional CO2 and erbium.YRG lasers. And these operate on a principle called photothermal absorption. So the laser light doesn't just burn indiscriminately, it is specifically attracted to the water molecules trapped inside your tissue.
Okay, wait, I want to make sure I'm visualizing this correctly. The laser hits the tissue, targets the water, and just heats it up.
That is the core mechanism, yeah. The water absorbs the photon energy, it rapidly vaporizes, and that creates a highly controlled microscopic column of thermal injury right in the vaginal wall.
Wow.
And then you have the second category, which is radiofrequency, or RF.
Right.
Now, RF doesn't use light at all. It uses high-frequency electromagnetic currents to create endogenous heat.
Endogenous meaning like internal.
Exactly, meaning it heats the tissue from the inside out through something called ionic agitation.
Ionic agitation sounds like a term straight from a physics textbook. What does that actually mean for the human tissue?
Well, think about rubbing your hands together really vigorously on a cold day.
Yeah, the friction generates heat.
Exactly. RF technology rapidly alternates electromagnetic currents, sometimes like millions of times per second.
Millions.
Millions. This forces the molecules and the ions in the deeper layers of the tissue to vibrate and crash into each other. And that microscopic friction generates deep heat without necessarily burning the surface layer.
Oh, that makes sense.
But regardless of whether a doctor uses a laser or RF, the ultimate physiological goal is identical. It's to cause controlled damage.
Causing damage to traumatic healing.
Exactly that. The localized heat triggers the body's natural wound healing cascade. It wakes up cells called fibroblasts, forcing them to basically remodel the structural matrix of the tissue.
It build it back stronger.
Right. They produce fresh collagen and elastin and stimulate new blood flow to the area.
See, I have to stop you there, because if you are listening to this and, crossing your legs right now, you are not alone.
Oh, I totally get that.
The idea of intentionally causing thermal injury to the vaginal wall sounds absolutely terrifying. And looking at our sources, specifically the FDA's 2018 safety communication, there's a massive red flag here.
There is, yes.
The FDA explicitly warned that these energy-based devices are not approved for vaginal rejuvenation.
Yeah.
They documented severe adverse events. We are talking severe vaginal burns, deep scarring, and recurring chronic pain.
Yeah, the reports were serious.
Right. Even if it is a medical procedure, a burn is a burn. How do organizations like NICE or AUGS justify risking chronic pain just to fix thinning tissue?
Well, that is the crucial tension in this entire field, really. And it comes down to a classic case of aesthetic marketing, just totally outpacing medical science.
How so?
The FDA's warning wasn't necessarily stating that the physics of the machines were inherently flawed. It was actually a reaction to how they were being sold. You had these unregulated midi spas and aggressive clinics promising vaginal rejuvenation as this quick cosmetic fix-all.
Right, like a lunchtime facial, but for your pelvis.
Exactly. And that term rejuvenation is entirely cosmetic. It lacks any clear medical definition. So the FDA was cracking down on powerful devices being wielded for vanity procedures by practitioners who, frankly, didn't fully understand the delicate anatomy of the pelvic floor.
Oh, okay. So it's the difference between seeing a board-certified specialist and getting a spa treatment that goes horribly wrong.
Exactly. Because in the hands of trained urogynecologists and dermatological specialists, these devices have a highly specific, very necessary application. They are used to treat a recognized, often debilitating medical condition called Genitourinary Syndrome of Menopause, or TSM.
Doesn't sound right.
When estrogen levels plummet during menopause, the vaginal tissue physically breaks down. It becomes paper thin, it loses its elasticity, and the blood supply diminishes severely. Women suffering from GSM often experience excruciating pain during intimacy, chronic dryness, and just persistent irritation.
So for these patients, the tissue is already compromised, and the controlled heat is a way to force the body to, rebuild it.
Yes. The heat penetrates down into the submucosa. Think of the submucosa as the thick, supportive foundation underneath a mattress.
Okay, good visual.
By triggering collagen production down there, you are genuinely helping restore the structural integrity of the tissue. But to your earlier point about safety, the UK NICE guidelines heavily emphasize that these devices are never first-line treatments.
Never the first thing you try.
Right. They require careful clinical governance, precise settings, and specialist supervision to avoid those exact scarring risks the FDA warned about.
Okay, that covers the mechanical side of things,
Yeah.
the heavy lifting of controlled damage. Now I want to look at the biological side of this puzzle, which is polynucleotides, or PNs.
The fish DNA.
Yes. I mentioned fish DNA in the beginning, and I was reading through the MDPI clinical studies we gathered. It keeps bringing up something called PDRN derived from, and I'm hoping I read this wrong, trout sperm. Please tell me I misread that.
You read it perfectly correctly, actually.
Ah.
It often catches people off guard, but polynucleotides are highly purified fragments of natural DNA, predominantly derived from the gonadal tissue, the sperm of trout or salmon.
Why on earth use fish DNA?
The reason is that salmonid DNA very closely mirrors human DNA. Interestingly, many aesthetic and women's health clinics actually prefer trout-derived polynucleotides over salmon.
Really? Why trout specifically?
The molecular structure of trout DNA is slightly more stable. Clinical data suggests it is generally better tolerated by patients who have highly sensitive or reactive immune systems.
Which is crucial for delicate areas.
Very crucial when treating delicate mucosal tissue. And the purification process is so intense that there are no actual proteins or fats left behind. It's just the pure DNA fractions.
I mean, I hear injectable gel, and my mind immediately goes to traditional dermal fillers like hyaluronic acid. Is this just a way to plump up the tissue?
Not at all, actually. A traditional hyaluronic acid filler essentially just sits in the tissue and acts as a sponge, holding on to water to physically inflate the space. Polynucleotides operate on a completely different biological level. They are powerful biostimulants, rich in that molecule you mentioned earlier, PDRN, or polydeoxyribonucleotide.
The MDPI papers describe PDRN as acting almost like an instruction manual for the cells. How does a piece of fish DNA actually instruct a human cell?
It all comes down to cellular receptors. When these DNA fragments are injected, they bind to specific receptors on your cells, primarily the adenosine A2A receptors.
Okay.
By binding there, they effectively flip a switch that tells the human cell to enter a deep healing and regenerative phase. They signal the body to actively repair itself. They neutralize damaging free radicals that cause cellular aging, and they trigger a process called angiogenesis.
Angiogenesis, meaning the creation of entirely new blood vessels.
Entirely new microblood vessels, yes. So you're not just masking the thinning tissue with a temporary filler, you are genuinely improving its biological function, bringing a fresh, permanent blood supply back to tissue that had been starved of it.
If I'm trying to picture how these two completely different things work together, it sounds like rehabilitating a struggling garden.
Oh, I like that.
Like the vaginal tissue suffering from severe atrophy is like dry, compacted, lifeless soil. The lasers and the radio frequency are like aerating the lawn.
Yeah.
You use heavy machinery to cause controlled microdamage, breaking up the hard dirt and forcing new roots to grow.
Yes.
And then the polynucleotides are the ultra-premium biologically active fertilizer that you pour into that freshly aerated soil, giving the struggling cells the exact molecular building blocks they need to thrive.
That is a phenomenal way to visualize the mechanism. Mechanical stimulation paired with deep cellular nourishment.
So if applying heat causes intentional tissue remodeling
Yeah.
and the DNA provides the healing blocks, putting them together seems like an obvious win. Can intimate polynucleotides be safely combined with RF and lasers? And if so, who is this actually for? Because I imagine you don't just walk into a clinic on a whim and ask for the laserfish combo.
You absolutely do not.
Oh.
The clinical consensus across all our sources is very clear on the target demographic. This combined approach is reserved for women dealing with incredibly persistent entrance-focused symptoms.
When you say entrance focus, you mean the discomfort is specifically at the opening of the vagina rather than deep inside the pelvic cavity.
Yes, clinicians are primarily looking at women who experience a sharp, burning, or stinging sensation right upon entry. The clinical literature frequently describes these as paper-cut micro-tears at the vestibule.
The vestibule being the opening.
Right, the highly sensitive tissue right at the vaginal opening. It is also utilized for women experiencing mild, entry-focused vaginal laxity, perhaps a few years after childbirth or during perimenopause.
Where the tissue feels like unsupported.
Unsupported, but also sore, fragile, and easily irritated. What's fascinating here is how doctors physically map out these two treatments. You don't just indiscriminately blast the laser and inject the DNA everywhere, you know?
No, the anatomical strategy must be highly specific.
Exactly. The energy devices, the deep heating RF, or the fractional lasers are generally deployed deeper inside the vaginal canal and into the submucosa we talked about earlier. They are doing the heavy lifting to create structural resilience, thicken the vaginal wall, and provide deep tissue tightening.
The deep lawn aerations.
Right. But the polynucleotide injectables are handled very differently. They are administered very superficially. A specialist will inject them precisely at the symptomatic hotspots.
Like the vestibule.
Yes, usually the vestibule or the posterior fourchette, which is the delicate band of tissue at the very back of the vaginal opening that is notoriously prone to tearing during intercourse. The PNs are placed there to provide surface-level hydration, to heal those specific microtears, and to restore what clinicians refer to as slip to the mucosal surface.
Okay, so deep structural remodeling combined with targeted surface-level healing. It makes complete logical sense. But there is a massive prerequisite here that every single medical guideline in our stack agrees on. Both AUGS and NICE emphasize that this combination is strictly adjunctive. Wait, so a patient cannot just start with this combination to fix their pain?
Never. A responsible clinician will not jump straight to lasers and polynucleotides. A patient should only consider this dual approach if they have already diligently tried and plateaued with foundational medical therapies.
What do those foundational therapies look like in practice, though?
They are non-negotiable baselines. First, a dedicated regimen of supervised pelvic floor muscle training. And to be clear, this doesn't mean just doing a few Kegels while sitting at a traffic light.
Right.
It means working hands-on with a specialized pelvic floor physiotherapist to ensure proper muscle relaxation, endurance, and coordination.
Because if the stinging and pain are actually being caused by an overactive spasming pelvic floor muscle, a laser is going to do absolutely nothing to fix that root cause.
It might even make it worse by adding physical trauma to a muscle that is already guarding.
Yikes. Yep.
The foundation also mandates using scheduled, non-hormonal moisturizers several times a week to condition the tissue, utilizing generous, high-quality lubricants during intimacy, and critically, applying local vaginal estrogen or DHEA over several months.
Assuming the patient doesn't have an oncological contraindication to hormones, of course.
Exactly.
So the protocol is to optimize the tissue as much as medically possible, first using standard care. If those paper-cut micro-tears and that stinging at the entrance still persist after months of physical therapy and estrogen, then you look at the EBD and polynucleotide synergy.
It is a deliberate, stepwise approach to patient care. You only escalate to the heavy machinery when the foundational biology needs a larger push.
So if applying heat causes intentional thermal tissue damage, and applying the DNA requires multiple needle injections, doing both at once sounds like a recipe for just overwhelming the immune system. How does a doctor physically sequence this without harming the patient? Do they just book a 2-hour block on a Tuesday and do it all?
The sequencing of these treatments is governed by incredibly strict rules, precisely to avoid overwhelming the immune system. According to the aesthetic and gynecological protocols we reviewed, these two modalities are almost never done simultaneously on the same day.
It's like trying to rebuild a house while the fire department is still actively spraying water on it. You have to let the fire go out first.
That is a brilliant way to look at it. If you
Huh.
hit the tissue with a fractional laser, you are intentionally initiating a massive inflammatory response. If you immediately follow that up by piercing that inflamed tissue with dozens of needle injections to deliver polynucleotides, you dramatically increase the risk of severe irritation, excessive swelling, and compounding the tissue injury far beyond what the body can handle.
Ouch. So what does the actual timeline look like for a patient going through this?
The standard clinical pathway usually begins with the energy devices. A patient will undergo a short series, typically 2 to 3 sessions of laser or RF. Crucially, these are spaced out by about 4 to 8 weeks to allow the fibroblasts time to actually remodel the tissue.
And where do the fish DNA injections fit into that calendar?
The polynucleotides are heavily staggered. A clinician might inject them at the halfway point between the device sessions. Or, more commonly, the injectable phase is only started after the mucosal tissue has fully settled from the initial device response.
How long does that take?
That settling period can take anywhere from a few days to a few weeks, depending on the aggressiveness of the laser setting.
Okay, put me in the shoes of the patient lying on the treatment table. What does this actually feel like? Because hearing phrases like thermal injury, ionic agitation, and needle injections in highly sensitive areas sounds daunting.
The physical sensations vary significantly depending on the tool in the doctor's hand. If a patient is receiving a fractional laser treatment, they generally describe it as a warm, intensely prickly sensation, almost like tiny, rapid rubber band snaps.
Okay. And the RF?
If the specialist is using radiofrequency, it doesn't have that sharp bite. It is described more as a deep, diffuse, building heat inside the pelvic cavity.
And the polynucleotide injections at the vestibule.
Well, because they are injected very superficially into tissue that is already tender and symptomatic, they cause a brief, sharp sting as the needle enters. And that's followed by a strange feeling of fullness or pressure as the viscous gel is deposited under the surface.
Doesn't sound fun.
It's not, which is why, to manage this, clinicians almost universally apply a strong topical numbing cream for about 20 minutes beforehand.
Phew, okay. But once the numbing cream wears off, when can that patient actually get back to their normal life?
You aren't bedridden, but you do need to respect the healing process. Patients are universally advised to avoid any high-friction activity for anywhere from 3 to 10 days after a session.
Really?
That means no cycling, no heavy lower body workouts, no hot tubs, and absolutely no penetrative sex.
Right. You have to let the newly planted seeds in the garden settle before you start walking all over the grass again.
And patience is key here. Because you are relying entirely on your own body to produce new collagen matrices and sprout new micro blood vessels, the results are gradual. It takes weeks, sometimes up to 3 months, to see the peak clinical improvement from a combined protocol.
We also need to talk about the red flags, the contraindications. Who must avoid this combination entirely?
The absolute no-go list is definitive and strictly enforced. Anyone with an active pelvic infection is excluded immediately. That includes bacterial vaginosis, thrush, or an active urinary tract infection.
Because the immune system is already busy.
Exactly. The immune system is already fighting a battle. You cannot introduce thermal trauma on top of that. Also, anyone experiencing unexplained postmenopausal bleeding must halt any aesthetic or regenerative treatments until that bleeding is fully investigated by a gynecologist.
To rule out cancer.
Primarily to rule out malignancies like endometrial cancer, yes. And anyone who has had recent pelvic or perineal surgery needs explicit clearance from their operating surgeon.
I imagine there are also specific warnings depending on the exact piece of technology being used. Like, if the clinic opts for radiofrequency, certain internal medical devices, like specific pacemakers or deep metal implants, can completely disqualify you because those electromagnetic currents can interfere with the hardware.
Spot on. And then there's the very unique, highly specific contraindication for the injectables.
Yes, I saw this in the MDPI paper, and it completely blew my mind. Because polynucleotides are derived from the gonads of trout or salmon, a severe seafood allergy could literally dictate your intimate wellness plan.
It really could.
If you are highly allergic to fish, you are usually excluded from this specific treatment to avoid a localized anaphylactic response. Those patients might have to look at alternative biostimulants like platelet-rich plasma, or PRP, which uses their own spun-down blood instead of marine DNA.
It is a fascinating, almost bizarre intersection of diet, immunology, and advanced regenerative medicine.
Truly.
But beyond the hard physiological indications, there is also a clinical philosophy that guides when a doctor needs to simply stop.
Stop the treatments entirely.
Yes. If we connect this to the bigger picture of responsible patient care, the guidelines are clear on reassessment. If a patient undergoes 2 sessions of this combined modality and their progress completely stalls,
Meaning the stinging isn't fading.
right, the stinging isn't fading, the tissue isn't thickening, the microtears aren't healing, the clinician shouldn't just blindly keep adding more expensive injections or cranking up the laser to a higher setting.
You don't just keep aggressively aerating and fertilizing the lawn if the grass is still completely dead. Something else is wrong with the soil.
A lack of response to these highly effective surface treatments is a massive diagnostic clue. It tells the physician that there is a deeper, unseen driver at play.
Like what?
The pain might actually be radiating from severe pelvic floor muscle overactivity or an underlying inflammatory condition like endometriosis or even nerve entrapment from a malpositioned perineal scar from a previous childbirth.
Wow.
Treating the surface mucosa won't fix a deeper structural, neurological, or muscular issue, which is why this combination is a powerful tool, but it is just one tool in a much broader urogynecological toolkit.
Okay, let's bring this all together.
Yes.
Yes, according to the clinical data, you absolutely can combine intimate polynucleotides with radiofrequency and fractional lasers. It is a biological 1-2 punch that pairs the deep mechanical resilience and collagen production of energy devices with the targeted cellular hydration and vascular repair of marine DNA.
But it is a treatment pathway defined by immense caution. It requires heavily staggered sequencing to protect the immune system. It requires strict safety and allergy checks, and it should absolutely only be deployed after foundational medical treatments, like pelvic floor physio and local estrogen have reached their maximum benefit.
So what does this all mean? For you listening, navigating your own healthcare journey, it means you don't have to settle for older treatments that only address half the problem.
Right.
But it also means you should be deeply skeptical of any flashy clinic promising a quick, all-in-one rejuvenation fix on your lunch break. True regenerative medicine respects the body's timelines. It's about careful, staged interventions that work with your biology, not against it. It highlights how vital it is to have a specialist who understands not just how to operate a laser, but how to diagnose the complex underlying causes of intimate discomfort. I want to leave you with a final thought to mull over. Something that steps slightly outside the clinical guidelines we've discussed today. We are looking at a medical frontier where science is getting incredibly adept at extracting highly specific, ancient regenerative signals from nature, like the DNA of a trout, and combining them with advanced modern physics like fractional light and electromagnetic currents. As these two worlds merge, where exactly is the line between natural healing and bioengineering?
That's a great question.
And if we can successfully repair the delicate, complex tissues of the human reproductive system using this exact merging of biomimetics and biomechanics, well, what other failing organs or tissues in the human body might soon be treated by this exact same approach?
It really reframes how we think about the limits of human healing.
It absolutely does. Thank you for joining us on this deep dive.